Good afternoon, everyone. Today, from the Department of Neuro-Radiology, we present a case of post-traumatic vertebro-vertebral fistula. We had a 38-year-old female who had a history of trauma with fall from stairs around 2 months back, after which she had mainly symptoms of some low back ache and she was otherwise okay. After about 1.5 to 2 months, she developed some pain on the right side of her neck, for which she did not have any relief on analgesics. So thereafter, she went for physiotherapy, and there was history of neck massage and vigorous physiotherapy and neck manipulation, which she took for around 15 days. And during this course, at homes, there was sudden appearance of swelling on the right side of her neck, which was rapidly progressing. And thereafter, she was taken first to her nearby medical center, from where she was referred to a private hospital. So, that's So initially, from the she was taken to a nearby medical hospital, and then thereafter she was taken to a private hospital near Delhi, where during her course she developed some respiratory distress. So in a private hospital, she was first intubated, and the first images that we have are of 24th January, where the contrast enhanced CT film is available, which is showing a large heterogeneously hyperdense collection, which is seen on the right side of the neck, which is extending towards the midline and into the prevertebral space, and it's displacing the trachea and the esophagus anteriorly and towards the contralateral side. By this time, the patient is already intubated and there's already a Rydel's tube in situ. So we have a large neck swelling, and on the superomedial aspect of the swelling, we see a vascular density. Therefore, with a high suspicion of a vascular cause of the right neck swelling. The bone windows at this point of time showed there was mild enterolisthesis of C2 over C3 with a small undisplaced fracture of the posterior inferior aspect of the C2 vertebral body. The same night, an emergency DSA was performed outside, which showed this is the right vertebral run, which shows there's no antegrade flow in the right vertebral artery. And what we see is the opacification of the vertebral venous plexus on the right vertebral artery run. The ICAs were fairly normal. And on the left vertebral artery run, we can see there is some abnormality here, and the basilar is also not filling very well on the left vertebral run also. Other left vertebral artery runs, we see multiple stenotic lesions in the left vertebral artery V2 segment and V3 segment, and with a dissecting pseudoaneurysm at the V2 V3 junction. And also there is a stenosis at the proximal V1 segment. And the next day, an MRI brain was performed, which showed acute infarcts involving bilateral cerebellar hemispheres. They're in the watershed territory. So the outside details are very sketchy, but from what we know from patient and a few documents that he had, that the patient had bradycardia, she collapsed and was twice given CPR, was intubated. Her echo done outside was normal. Thereafter, the patient couldn't afford treatment outside in the private hospital. And were then referred to and brought to AIIMS New Delhi on 27th and presented to emergency at around 10 p.m. Patient on arrival was E4VT-M6, was sedated and was admitted under CTVS department. And the next day, the patient was taken up for endovascular embolization. These are the pre-embo CT images where we show again the same right-sided neck hematoma, which is compressing the midline structures. Just a quick run of the same. And we can also see the bilateral, already established bilateral posterior circulation in parts. Thereafter, first we took some diagnostic runs. This is the arch run, which is showing the arteriovenous fistula at the level of C5, C6 arising from the right vertebral artery, and also the stenotic segments of the left vertebral artery. These are the selective runs for the this is the right vertebral artery run, where we can see there's a long segment of dissection, which is the thin dissection flap, which is seen, which is almost arising from the origin of the artery. Here, this is the level of the fistula, from where we see first there is a pseudoaneurysm which is arising, and thereafter this is the fistula, from where we can see the filling of the vertebral venous plexus. Further distal to the fistula, there is severe stenosis and irregularity involving the V2 vertebral artery, and there is another pseudoaneurysm which is arising at the level of distal V2 vertebral artery. And there is no forward filling of the basilar from the right vertebral artery. However, the right pica is seen filling from the right vertebral artery. This is the lateral run, which is showing similar findings. Stills of the same. Then we took the left vertebral run, which again the stenosis in the proximal V1 segment has significantly resolved, but still there is a stenosis of the distal V2 as well as the V3 segment with the dissecting pseudoaneurysm in the vertebral artery. However, we can see there is good opacification of the basilar, the posterior cerebral arteries, the superior cerebral arteries, the left-sided pica, and good perfusion of the posterior circulation, except the right pica, which is coming from the right vertebral artery. The ICA runs were normal bilaterally. And so now, after this, we were considering our treatment options. Treatment options could either be reconstructive, where we try to preserve the vertebral artery, the ipsilateral. However, in view of a very long segment of the diseased artery with pseudoaneurysm at two levels and very severely stenotic artery, we thought, and also keeping in view that the posterior circulation is being well compensated by the contralateral artery, we decided to go for parent artery occlusion in this case. And this, so we took a guider up into the right vertebral artery. This is balloon inflation, and after 4 minutes of balloon inflation, we can see there is almost complete exclusion of the vertebro-vertebral fistula. And after this, we proceeded with the parent artery occlusion, where we first put some coils in the left vertebral artery. However, there was still some residual filling of the fistula through the interstices of the coils. And then thereafter, we used 60% glue to occlude the rest of the vertebral artery. And this post coil and glue embolization, we can see on the right vertebral artery, there is no filling of the vertebral artery or the fistula. Thereafter, we waited for 10 minutes and we went to the left vertebral artery to look for the patency. And on the left vertebral artery injection, now we can see that there is good antegrade flow. However, there is also steal happening from the left vertebral artery with filling of both the pseudoaneurysms and the vertebral artery. So at this point of time, we thought that if we need to trap this, we will probably go from the contralateral side and then complete the procedure. However, we waited for another 10 minutes and we took another run where we can see that now the distal V4 of the right vertebral artery is filling well. We can also see the right pica is now filling from the left vertebral artery, and proximally there is progressive occlusion. So there is complete exclusion of the fistula as well as of the diseased segment of the vertebral artery with exclusion of the pseudoaneurysms. And hence we stopped our, these are the still images showing the same, and hence we stopped the procedure at this stage. After this, these are the post-embo runs showing the coil mass and glue in situ in the right vertebral artery, and the post-embo CT showing no evidence of any new hemorrhage or any new stroke. And after this, patient was hemodynamically stabilized. Dr. Balaji from CTVS will tell about the ICU stay.
Good afternoon, my teachers and my colleagues. Patient was received from cath lab after coiling the CTVS ICU. Patient had a hypertension of systolic 170 by 110, and BP was controlled with nitroglycerin infusions at 2 mg per kg per minute. And patient was given antibiotics and diuretics. Diuretics as titrated as per the clinical scenario. And patient was allowed RT feeds from day 1. And the patient was weaned from ventilator gradually and extubated on day 4. Subsequently, NTG infusion was tapered off and BP was converted to oral amlodipine. The neck swelling which was there on the right side was managed conservatively with magnesium sulfate dressings, and the patient was shifted to ward on day 6 and orally allowed gradually and continued limb and chest physiotherapy. Over to you.
Once the patient stabilized and her after second day, 2 days of the procedure, once her sensorium improved, we noticed some right upper limb weakness in the patient, and the power was 2/5 in the right upper limb, and the weakness was more in the distal aspect. And clinically, the localization was either in the right brachial plexus, which was more likely in our case since we had a very large hematoma on the right side of the neck, and or it could be a left motor cortex, which was very unlikely since her anterior circulation was well preserved and there were no infarcts on that side. So there are, after the patient stabilized, we did a post-procedure MRI for her brachial plexus, which showed a large collection, obviously compressing upon the brachial plexus and with thickening and edema seen along the brachial plexus roots and trunks. And so this was thought as the likely cause of a right upper limb weakness. Surgical. Also, at the same time, a contrast enhanced MRI was done, which showed the left vertebral artery filling well, filling the posterior circulation well, also filling the distal V4. The pica is now patent again, and also there was some residual. There's also the traumatic pseudoaneurysm at the V3 V4 junction. We took a surgical consult for her neck hematoma, and she was advised conservative management for the same, and she was given physiotherapy for the right upper limb. And subsequently, she had no cerebellar symptoms or any ischemic symptoms. And after stabilization, patient was discharged and kept on follow-up. And on recent follow-up, we can see that the neck swelling has near completely subsided now, and her limb weakness is also gradually improved, especially of the wrist and the uh, wrist and the elbow. Only she has residual weakness at her shoulder, and with her overhead abduction being only, uh, she's not able to do overhead abduction. And we've repeated an MRI for her, which shows near complete resolution of the swelling of the neck. There is, however, residual hyperintensity along the brachial plexus. Also, a contrast MRI reveals the healing of the dissecting stenosis in the vertebral artery, and we'll see a traumatic pseudoaneurysm, which we plan to follow up and then subsequently see if this needs treatment. And MRI brain reveals the chronic infarcts which she developed before she was intervened. Just a quick word about vertebro-vertebral fistulae. The most common causes are blunt or penetrating trauma to the neck, which and also sometimes it can be iatrogenic with during central line placement or when we are performing direct punches for the carotid artery. Vasculopathies like Ehlers-Danlos syndrome, NF1, can also lead to formation of spontaneous vertebro-vertebral fistulae. Endovascular embolization remains the treatment of choice, and the parent artery occlusion has been considered is fairly safe if the patient's hemodynamics allow for the same. However, in most cases, we should aim for trapping of the fistula to prevent retrograde steal from the contralateral vertebral artery. And however, in cases where the dominant vertebral artery is affected, we need to preserve the parent artery and using reconstructive techniques where we can use stent graft or we can use stent assisted coiling in such cases. However, stent graft sometimes can be very rigid and stent assisted coiling will maybe needed. Detachable balloons, which were erstwhile used for closing of the fistulae, are no longer available and therefore no longer a treatment modality available to us. The choice of technique belongs to the anatomy of the fistula, the location, whether it's low or a high flow fistula, the parent vessel anatomy, also again the hemodynamics, whether there is feasibility of parent vessel occlusion or not. And low flow fistulae with evident fistulous point can be occluded at the fistulous point by progressive coil occlusion. However, in cases of high flow fistula, we may need to use both coils as well as glue to achieve a complete cure. And these are the few articles that I went through. These two are the case series. First is basically traumatic injuries of vertebral artery, where 16 of these 18 patients had vertebral fistulas, which were managed either by balloon occlusion, coil embolization, or stent deployment. An older top where both spontaneous as well as traumatic fistula were treated, and they here in this article they tried to preserve the vertebral artery in most of the cases. And further similar case reports of traumatic vertebral fistulas which have been treated with parent artery occlusion. Thank you, sir. I've finished.
Thank you, Ashrima. Any questions? Almost five. I think this was treated in January, and we did the yesterday follow-up. We have at least two follow-up. One the midterm, and now the latest was yesterday's follow-up. We we have sent the consultation to the neurosurgery so that a neurosurgical evacuation, immediate decompression can benefit the faster recovery. But it was advised for a conservative management, so we didn't press for it. And we also very well know that the hematoma can regress. The only point is how much residual deficit the patient is left with. That was unpredictable here. But fortunately, patient has done quite well. And hematoma evacuation, I don't know what is the incidence of infection. Shashwat, are you there? What is the
Confines.
yeah?
Actually within the soft tissue of the neck, so nerves are actually able
Very
to
close,
survive. Mostly neuropraxia is as is evident from the recovery. It is usually neuropraxia, and we expect full recovery in about
So
6 months' time.
do you suspect also the brachial plexus injury in this case?
No, because brachial plexus here it is the hematoma is actually in the soft tissue of the neck. It is not extending into the whatever.
Neural phenomena.
Yeah, neural phenomena. If it was extending into epidural space, you would have considered surgical decompression.
So that was purely on a technical ground, and you believe that the surgical evacuation may not cause immediate decompression of the brachial plexus.
No, it can cause, but we like in this case it was large hematoma, and usually they will resolve by their own. And as it has happened in this case with the full neurological recovery usually.
Yes. Okay. Any?
Terms of antiplatelets and anticoagulation after coiling.
So parent artery occlusion doesn't require usually the continuation of aspirin or Plavix, whatever. But here the major concern was there was a hematoma. So if we put a patient on antiplatelet, what are the chances of hematoma means expansion? That was main concern. The only point in favor of aspirin or clopid was the dissection on the other side, the left side. But had it been a benign lesion, no hematoma, then would have definitely put the patient on antiplatelet. Sure. Thank you.
Good afternoon, everyone. So the Department of Neurosurgery from Trauma Center will be presenting the CCR, which is entitled that better can be the enemy of good. This must always be remembered by surgeons when embarking upon a surgical exercise, because you may plan for something great, but ultimately you may have to compromise and still end up with an acceptable result. So, and sometimes we may harm the patient, in fact, by trying to be extremely perfect or having the best post-operative imaging. So that is the crux of this presentation. So now I invite our spine fellow, former spine fellow, Dr. Hitesh Inder Rai, to present this CCR.
Good afternoon, respected faculty and dear colleagues. So today we'll be discussing about a 50-year-old male who was a jail inmate who presents with spastic quadriparesis for the past 1 month and breathing difficulty for the past 1 day, had comorbidities such as schizophrenia and chronic alcoholism, and he had a happening past history of two road traffic accidents. One was in 2004 when he had a head injury and a right frontal craniotomy with bleed evacuation was done. However, he had a bone flap infection which was subsequently removed in the next surgery. And the other RTA was in 2015 when he had a cervical spine injury, and there was injury of the levels of C4 to 6. So he had a C4 to 6 corpectomy with the cage and plating. Only anterior surgery was done. There was no posterior surgery that was done, and it was done in a private hospital in Mumbai. On examination, the patient was E4 VTM6, had a sensory level of C4, and the power in the upper limbs on at shoulder elbow level was 3 by 5 bilaterally, and wrist flexion and extension were 2 by 5 and 1 by 5, and on the left side was 1 by 5 and 0 by 5. The patient was quadriparetic and paraplegic with spasticity in all four limbs. The course in the hospital was quite eventful, and he presented to us in casualty with E4 V5 M6, that is the full score, but had respiratory distress, and but because of subglottic stenosis could not be intubated and had to be tracheostomized by the ENT team. Then he was E4 VT M6 quadriparetic and was on low dose inotropes and had DVT in the left popliteal vein, for which anticoagulation was done. So finally the patient was stabilized, and then the patient was considered for evaluation. Coming to the preoperative imaging, this was the CT scan of the head. So here you can see a right frontal gliotic scar with a healed craniotomy defect. Coming to the cervical CTs, so this is the sagittal scan. So here you can see that there is facetal fusion. There is a cervical deformity in the form of cervical kyphosis, which is around 44 degrees. And here you can see the cervical cage and the cervical plate that So here you can see the cervical deformity in the form of cervical kyphosis, that is around 44 degrees, and you can see the cervical cage and dorsal to the cervical cage and ventral to the spinal cord. You can see heterotopic bone formation, and which is a kind of internal gibbous, and it is compressing on the spinal cord, and the effective canal diameter is reduced. Now coming to the construct, here you can see that the cage has subsided into the suprajacent and the subjacent segments, and you can also see that the plate is also malaligned and the lower screws of the plate are almost going to come out. And posteriorly you can see the facet fusions too. So the cervical kyphosis is around 44 degrees as measured by the tangent method, and the normal cervical lordosis, as we know, is minus 15 to minus 25 degrees. Now coming to the axial cuts. So these are the upper screws of the plate, and here you can see the cage, and you can see the ventral bone, heterotopic bone formation that is compressing the spinal cord. These are the sagittal MRIs, and the yellow arrows show the cord, the myelomalacic cord that is draping over the anterior heterotopic bone that is causing the spinal cord compression, and the red arrows show the actual compression happening. Similar findings are shown on the axial cuts. The yellow arrows show the myelomalacia and the red arrows show the compression. So based on this radiology, we planned a posterior approach first, and so our reason for doing a posterior approach first was that we'll instrument the posterior spine, and we'll break the posterior facetal adhesions. So we'll do the facetal release, which will aid in the which will aid us to get the deformity correction when we approach the patient from ventral. So what we did was we did a C2 to D2 instrumentation, and the C2 pars on the left side was adequate for a par screw, but on the right side there was a high riding vertebral artery. So we had to do a translaminar screw. C3 to 5 we did lateral mass screws, and C6 to D2 we did freehand pedicle screws. We did the facetal releases, but doing all this thing, it was approximately a 5-hour job, and a lot of at around 3 liters of blood loss was there, and there was instability, so it prevented us from doing the anterior approach in the same sitting. These are the final x-rays. You can see the screws in the desired position. However, in the AP view, you can see that the cage is quite tilted in the coronal plane along with the plate. So after 3 days, after stabilizing the patient, we did an anterior approach, and we removed the cervical mesh cage, plate and screws, and we decompressed the cord by drilling the heterotopic bone. These were the x-rays after the second stage, and you can see that some deformity correction has also been done in this sitting only. This is the CT scan. And we can see that this bone has been drilled, and the screws are adequately placed. These are the axial cuts. This is the translaminar screw. These are the lateral mass screws. So after we did the second surgery, we drilled the anterior bony wedge, and a corpectomy trough was formed. So this is the corpectomy trough that was formed. So here we had two options. One was we put a cage, and the other was we leave it as it is. But as you can see that this shaped cage cannot be molded or is not available. So we decided that we'll keep it as it is. We won't put a cage here. So in the third stage, we did a posterior approach. We fixed the screws with the rod, and we did bone grafting and fusion. These are the final x-rays, and this is the final construct. And here you can see that this tulip here is of the translaminar screw, and so we had to place an extra rod so that we can join it with the main construct, because the rod could not be molded at such an acute angle. And here you can see that in the AP scans, you can see that some amount of coronal deformity correction has been achieved, and in sagittal scan also we can see that some amount of sagittal correction has also been achieved. This is the final CT scan. This is the final MRI. On the sagittal cut, you can see that there is a CSF shadow in front of the cord. However, because of the artifacts by the screws, you cannot appreciate that on axial cuts. This is the final X-ray. So in the post-op course, the patient was E4VT M6 on tracheostomy tube, and currently room air trial is being given to the patient. So our plan is to decannulate the patient and do physiotherapy. The power in the upper limb was same 3 by 5. However, the power in the lower limbs improved to 3 by 5 and 2 by 5 on the right and left side respectively. These are the clinical videos. Now I invite Dr. Shashwat to continue the discussion further.
So, as you can see that we had initially drawn a very ambitious surgical plan for this patient, which consisted of releasing the facets posteriorly, like breaking the deformity a little bit, then going anteriorly and correcting the deformity, placing a cage, and then finally rolling the patient over again for a final fixation. But our plan went haywire because of several causes. One was that the patient had was on anticoagulants, and there was significant blood loss during initial part of the approach, which consisted of posterior exposure and just release of the facets. And that's why we had to postpone our anterior approach till the patient stabilized. And we also realized that not only we required to break the fusion between the facets, but also the fusion had also occurred at the level of the uncovertebral joints. So these uncovertebral joints are very close to the vertebral artery. So accessing them posteriorly is fraught with difficulty and also risk to the vertebral artery. So so they had to be, if we wanted some correction, then they had to be taken down anteriorly. So so that's why we just instrumented the patient, just placed our screws, and then we planned for an anterior approach. But then we realized that after doing the corpectomy, that approaching these uncovertebral joints was not easy. We could release it on one side, but on the other side it was very difficult because of the deformity and its close proximity to the vertebral artery. So, and naturally the corpectomy trough that had formed was not amenable to being replaced by a straight cage which is available, which is commercially available. Either had we had to custom design cage for this patient, which was again going to be very difficult because then we had to do 3D metal printing, which is very expensive, and this patient was a jail inmate anyway, so he could not afford it, and all his treatment was being funded by exemptions. So naturally, we thought that what could we do? So we then depended on the anatomical peculiarity of the cervical spine. Like we thought that it is not like other portions of the spine where we don't have strong structural lateral support which can replace the load bearing anterior vertebral column, just the body, the weight bearing bodies. Here we had cervical spine has these uncovertebral joints which can take part of the weight, and also these facet joints here, which are so aligned that they can also participate in weight bearing. This is in contrast to the lumbar segments and the thoracic segments here, where there is this kind of structural support is missing. So we depended on this and we abandoned the this idea of placing a cage. And in retrospect, our decision was right, because there are several considerations in deformity correction. We must observe deformity angles in all three planes, and there are several issues because these are prolonged surgeries. So we must take into account the comorbidities, the neurology of the patient, and we must also focus on the hemodynamic stability during surgery. So lots of times these approaches must be performed in several stages, which may be temporally separated also. So looking in retrospect, because the patient recovered well, I feel that we looked for literature evidence of previous such case reports, but I couldn't find any. So we are going to actually report this case, that this is also a good idea, that if you can't fit in a cage, then just leave it like that, and with good robust posterior fusion, then patient may be able to tolerate this kind of bony removal easily. So in conclusion, I would say that aiming for neural decompression is preferable to achieving a perfect correction of deformity, and the cervical spinal segments have robust lateral supporting elements, lateral mass and covertebral joints. And even with significant loss of vertebral body support, these elements can maintain correction. So rather than going in for good looking x-rays, we should aim for a neural decompression and best helping the patient. And in long segment complex coronal plane deformities, cage placement for anterior support can be impossible unless they are custom designed or 3D printed. So this may be an economical way of circumventing these difficulties. That's huh? This follow-up is around 2 months now, because this I operated just before the vacations. This last MRI has been done 2 months. So by this time on CT also the fusion was evident along the lateral pillars. Huh? No, no, he's still admitted with us, because we are planning to decannulate and then only send him, because coming back from the jail is very difficult.